Like I said, it's just fascinating to hear everything, and my sincerest apologies. I'm actually going to use some old-fashioned techniques to bring it all together to treat spinal deformity. But why are we doing it, right? I think pain and disability is the main reason we treat. It's not deformity in adults. It is pain and disability. We know about the cone of economy. We know we need sagittal balance. We know that bad sagittal balance is bad for your quality of life. We know that it significantly affects your health, so much so, back pain and deformity is worse than heart and lung disease. I'm not kidding, guys, look it up. It's highly disabling in adult deformity, that back pain. And we know that combined scoliosis, the poor sagittal balance, is worse than someone with limited vision and limited arms and leg use. This is pretty significant disability. So we're really dealing with something that's pretty significant. We know that surgery works better than non-surgery, and that's consistently been shown by Keith Bidwell's group and others. And they do much better with less back pain and disability. So the argument that should we operate on these, I think, needs to rest. But we know that surgery does better for these patients and maintains itself for up to 5 years, well beyond 2 years. And I think we all would sort of agree with that, and we're improving the qualities and getting to a better point in the quality of life. That's why we operate. The naysayers who keep saying, why do we operate on deformity? That's the reason to operate on deformity. But then look at the risk benefit. As you get older, your complication rates go higher and higher. And I think that's important again. The elderly they are, higher the complication rates, the more osteotomies you do, higher the complication rate. And I want you guys to stay with this thought. So yes, we should operate, but the older you are and the osteotomies you do, the complications go up. We now know what the alignment parameters are. I think we all know that. But we also know it matters what age you are. The higher you are in your age, those parameters need to be modified. And patients are highly adapted to poor sagittal balance. So we have to age adjust our goals and probably won't have more iatrogenic complications like BJKs. But what do we tell our patients? This is important. This is from the ISSG. 73% will require blood transfusion. Will have a major complication, and 76% will go to ICU. This is where we are with deformity. So yes, it's disabling. Yes, we know we can do it better. Yes, we know it's effective. And yes, we know we need to operate, but it comes with a high complication rate. And that's why let's not throw out the baby with the bathwater. We can do a better job. We have to treat it, and we hopefully can do it better. And that's what I keep saying in the elderly patient. Let's reduce that post-surgical physiological load. Big terms, but I know you guys understand it. And the way we do that is avoid the osteotomy and the blood loss that reduces that physiological load. And I think that's what we should think about. Use ligamentattaxis to achieve it, to get the restoration of the spine. And yes, the entire strategy should be MIS. Because again, with my ISSG colleagues, Juan's here and Adam Cantor's there, we've shown again and again, hybrid doesn't really achieve that. You have the complications of MIS, open and laterals now. And you're really landing up in the same place. So if we're going to go to adult deformity in a big way, we have to adapt circumferential MIS techniques. And that's my only other quick plea, that's where we need to go. Because just because it's easier to go in the back doesn't mean it's better. But on the flip side, though, if you don't know what you're doing, you will not know what you're affecting, it is going to be minimally effective. You have to know what you're doing with these techniques, right? And we have all these techniques now. We heard them, unbelievable amount of technology available today. How do we put it together to treat major deformity? And we've used this protocol for years now. Every single non-fused spinal deformity gets the same protocol. Even if they're fused, it doesn't matter how many levels of fusion, what levels of fused. Is there any open disc you can access? This protocol works across the board in any type of deformity. And the indication should not change in any way. Just because you do MIS, you don't operate on somebody who would not have operated. I think that's a very strong comment I'm going to make, and that is sad when people operate on people who would not have operated. Treat the patient. Clinical indication, we all know you have the quality of life. I won't do deformity. just will not do it. Do a decompressor or do a TLIF. And obviously all the other points we've talked about to me are the main indications clinical. And radiologically, every one of these patients have been treated circumferentially MIS by us, and they come in all categories, sagittal or coronal. How do we do that? X-rays on everybody. We know we get full-length X-rays. EOS we have today, obviously measure what you need to measure, know where you need to go, know what you have, isolate that, and know what to do. More importantly, know whether it's a degenerative or a correcting curve. A degenerative curve will always correct itself. It's very easy. An idiopathic curve is not. You need reduction, translation, and derotation techniques percutaneously to correct that curve without an osteotomy. It's an added level. So understand what curve you're treating, and then you'll be able to get to it circumferential MIS. MRI is critical. We already talked about for obvious reasons. For us, it really is the approach. I talked earlier, with the bifurcation or lateral to the aorta in the lateral approach. That's what we're always looking at. Can I get pre-service lateral to the aorta? Looking at the bifurcation. We don't even look at the iliac crest anymore. I talked about in the comment. That's your pre-service approach, right in front of the service. Those are incisions. There's a fantastic cadaveric work by Anand and Vanita before. I thought it was a really good approach. 5-1, clearly, I prefer vascular surgeon. Get us the exposure. It's a lateral ALIF. It basically is a lateral ALIF. I think it was shown very elegantly earlier. We'll do 5-1, move to 4-5, 3-4, 2-3, and get as many levels as we can, all in the lateral approach. CT scan, very low threshold to do. The biggest reason I do it is to look at fused levels. They will be fused and it's fully on X-ray and MRI. It's a CT scan that's going to tell you if it's fused, is there osteophytic bridging? And if it's fused, obviously you can't do a lateral. You got to work yourself above or below to get that global correction and see what discs you have to correct. Bone density is highly critical. You're not going to achieve the correction if your bone density is not good. We use teriparatide very frequently, looking at the bone density, put them on it. It's a huge limb saver. If you have an osteoporotic patient, you cannot do teriparatide. Do not do MIS, please. It will not work. So I think about it, what you're doing, how you're achieving correction. This is all part of a protocol. It's well published longitudinally for years. The essential part is laterals all on the first stage. We tend to do it in lateral approach, all levels lateral, including lateral ALIF. Get them up walking that day or the next day. Second day, they get an X-ray. That X-ray has been a game changer, what we need to do posteriorly. And then we go posteriorly without osteotomies, percutaneously reduce, translate, derotate, and correct the deformity. We've never had someone SVA greater than 10 or PILL greater than 40 so far. I've always said I couldn't get this paper published, but I guess if you cannot do a good lateral or you fail in your laterals, then you have the opportunity to do an osteotomy when you do go posteriorly. Y stage, you see indirect reduction of stenosis. For us, it's being used. I know it's reduced. The intervening X-ray, I told you, it makes a big change to what we need to do. But more importantly, and untalked about, you have 2 short surgeries in an elderly 70-year-old patient with 3 to 4 hours each, rather than an 8-hour surgery. And we have not talked much about operative duration as a single predictor of complications. Look at that. There's a single level lumbar surgery greater than 5 hours, a 10-fold increase in wound adhesion, 17 deep thrombosis, 9-fold increase in sepsis, and extrapolate that to 4, 5 levels now. ALL release, we really don't do it at all in a non-fused patient. We found we don't need it. My only 2 indications of these 2, 4-to-1 fusion, 3-4 skyphotic, or a 3-to-1 fusion, 2-3 skyphotic, fantastic procedure in place of a PSO. An ALL release with ACR, really good procedure with these 2 indications. So, quick example is a big coronal deformity, 55-70 degree curve, thoracic and lumbar double major, if you will, PILL mismatch 20. Here's the MRI. We know we can get access lateral to the aorta. And here's a CT scan showing me no particular fusion at any level. That's all we're really looking at, besides all the other obvious ones like sclerosis and gas. She got a 5-1 and 4-5 ALIF because she got a high bifurcation. And so that's what you do. Lateral ALIF, go and into laterals at the other levels. Get your lordosis every single level as needed. Place your graft anteriorly. That's a post-stage 1. And you can see how that thoracic spine starts to unwind. Not fully though. Laterally got the alignment. She's up, walking, no radicular symptoms. And now we can plan your posterior, which right now would basically be a thoracolumbar to pelvic fusion. But see that thoracic spine unwind. It unraveled the leg length discrepancy. She had a 1-inch leg length discrepancy. In the astute among you will see it. Or her right leg is longer. And so once you correct that, and here you can see her 1 year later, completely corrected with the leg length, leg lift, pre-op, intervening stage, and post-op. The thoracic spine does not need to be treated. We've got many of these. This has been a game changer. We don't need to go T2 to pelvis for these patients. Here's another patient, massive coronal sagittal deformity. I only showed this with 3/4 fused, which we never saw in X-ray or MRI. And that's why we stopped bending films. This is what's more important. You cannot do a lateral at this level, obviously. And here's our pre-op post-stage 1, and it becomes a T10 to pelvis case, stage 2. Similarly, coronal, stage 1, post-stage 1, and here's stage 2. Leave the thoracic curve. As alone, they didn't need much anyway here. There's another patient, physician from Louisiana. This we did all the same day. It was a really healthy guy and did it all the same day. And again, you can see it all corrected using the same protocol. This is 10 years out, same protocol we've used for 13 years now. Only small changes have been made over time in the techniques. And here's one 12 years out, 2008. You can see with the thoracic curve not corrected. For osteoporosis, I'm excited that this may be of some use, screw anchors. Looking forward to using it more and telling you guys about it. I think this might be important in the osteoporotics to get better fixation. We shall see. It gives good pull-out strength, 5 times the peak insertion torque. We published longitudinally for years on our patients, continuing to do so with long-term results now. And I'll leave you with this for severe ASD. 136 patients is in print, and right now, 2-year minimum, 8 and 7 levels, average fused, across the board, functional results and clinical results, radiological outcomes, well-maintained, good lordosis, and PILL correction for severe deformity. We're not talking a mild or moderate. Our intra-op complications with 2, luckily got good control of both. This is first 30 days complications. The interesting thing is nothing catastrophic. PE, acute CVA, were all treated with anticoagulants, DVT. This was unrelated, cerebral hemorrhage, obstructive hydrocephalus. Urethral, we've had 3 early on in our series. We published that as a separate paper. But I think what's important is this part that has been most fascinating, the hardware failure in PJK rate of 2.2%. And I think the only way I can explain this is a physiological harmonious correction without a single osteotomy. So you're not stressing your construct out with a robust anterior column support. We don't do any coronal bends. It's a very smooth sagittal bend with derotation techniques, no in situ bending. So at the end of the day, I think we got to know what we're doing, harness the technology. We see amazing technology out there, use it proactively and judiciously, and then ultimately get a physiological correction and maximize lordosis. And I think we'll be places in treating adult severe deformity in all MIS fashion. If you want to see it, come, enjoy with us. Spend 6 months, my plug for a fellowship, purely on MIS deformity. And with that, thank you, and giving me the opportunity to share our results. Really been a pleasure. Thank you.
Thank you, Neel. As always, your passion is amazing, and the clarity of your presentation, supported by your data, is quite compelling. And I'm still amazed at how you are able to get away with some of your instrumentations that don't go to the levels that we usually are taught to go to, like on the top and the bottom. So I appreciate the fervor and everything like that. We've talked about this at one of our SSF sessions, so I'll repeat the question here as everybody's present. Stiffness of a curve is a pretty big deal. Do you change your approach when the patient is more flexible in their coronal deformity or is more rigid? Is there a change in your paradigm in that regard?
I think the easiest answer to that, Jens, thank you for that question. And the answer is no. It definitely is easier to get a disc release in a flexible curve by doing the same thing we do. whereas it's a stiff and rigid curve as looking on bending force. As long as it's not fused on CT scan, I just got to work harder at the disc to get it released. So the lateral for me is a disc release procedure with the interbody giving me the alignment and correction. And I think that's the best way to kind of look at it. So yes, I got to work harder if it's a rigid curve, but the procedure and protocol is exactly the same.
So
No, just keep going. No, Neel, that's good. So Neel, lately, have you becoming more aggressive or more discreet in terms of your approach to deformities? In terms of, are you doing as much as T10 to iliacs as 5-6 years ago? Are your numbers lowering? Are you doing some cases actually open in deformity that you said, you know what, MIS is too much, or what is your current situation?
I'll answer the second one first. The answer is no, we've not converted open to a single patient. I've not done open surgery for a non-fused deformity literally in 17 years. If it's fused, that's completely different. I do it myself. Having said that, no, nothing has changed. The one thing I've been a very strong advocate of is I do not think we should compromise what we do just because we do it MIS. At the end of the day, the global deformity correction remains the same. We still got to get it. We have to achieve it. And so the answer is no. The only thing that's changed, though, is a lot of patients that would have done T2 to pelvis, maybe even 5-10 years ago, that staging has really been a paradigm shift to switch to T10, T11, T12 to pelvis. That's probably the biggest change in terms of that staging has helped us.